Hi, I'm Dr. Edelman. For those of you that don't know me, I'm just one of the APDs. I specialize in ambulatory education. I'm sorry if I haven't met you yet. And I'm a site director at WFR. I'm going to talk about a treatment for obesity only. I give the first years kind of what is obesity, why do we care about it? I know it's something that, even though it's very common, is not necessarily the most exciting thing for people to learn about. And so I'm going to try to make it really as interactive as I can, but also as practical, because lots of our patients have it. It's easy to kind of ignore it and say, okay, I'm going to deal with all these other issues. But of course, I think we know both intuitively and hopefully now we'll talk explicitly about like why it's so important. And so I'm just going to talk about, I'll start, okay? So why should we care about obesity? I'm sure you guys could all give a bunch of reasons. It's something that's all over your board exams. So you should also be prepared to kind of talk a little bit about it. And, we measure BMI, and I know everybody knows that weight, everybody, I'm assuming in their second and third year, knows how important waist circumference is. And that's because of, your visceral fat. And like one slide on pathophysiology about why we really care about this visceral fat. So, in general, you have these adipocytes, they work fine. We don't even have to talk about what their function is right now, though I'll do a little bit later. And what happens is when you get more and more of them, they no longer go to the subcutaneous fat, they go into your visceral fat. And they get so big that they kind of outgrow their blood supply. And what happens in any tissue in our body, whenever we outgrow our blood supply, it causes apoptosis, it causes a pro-inflammatory reaction. So what you see here is basically a big bundle of a pro-inflammatory fat mass, okay? It's very complicated, but just to keep that very simple. So here we go, and we have a bunch of adipocytes that are around the visceral organs. So somebody tell me, what happens if you have like a pro-inflammatory molecule sitting right next to your heart? What do you think would happen? You can chat or say it out loud.
I think they will send the heart into an overdrive.
It definitely could. Yeah. What else?
Also, maybe you can increase the risk of cardiac events. Like ruptures in the eye.
Thank you, Dr. Romay. I recognize your voice. Yeah, of course, right? So it's going to cause endothelial dysfunction. It causes arterial stiffness, vasoconstriction, increased coronary artery score. It causes a whole hypercoagulable state. And this is what causes, or a big reason why it causes, CAD, peripheral vascular disease, PAD, and hypertension, right? And of course, when you're in a hypercoagulable state, you're going to increase cardiovascular risk, CVA risk, stroke risk, right? And then I kind of said this last time to the interns, but also for those of you that are interested in heme-onc, I put these little pink ones everywhere, and it's basically cancer. Obesity causes a huge cancer risk for basically all solid organs. Depending on which type, it's a higher rate of association, but it's really high. And it's something that we don't think about, but it's true. Really, liquid cancers, there isn't so much of an association, but most solid organ cancers there are. So that's part of why we care. It's the adiposopathy. I can't even say it, and I've tried to say it many times, but it's basically this pro-inflammatory molecule that creates huge problems. And then there's just literally the mass effect, and we call that the fat mass disease. So pulmonologists in the making, tell me why you think it matters to have fat mass right up here around your neck.
Obstructive sleep apnea.
Yeah, exactly. It's just OSA, right? What about around your heart, cardiologist? This is the fat mass, right? Not the inflammatory part of it. Can you contract and expand well, right? If you have something constricting you? No. So it's a big part of diastolic heart failure and impaired relaxation, okay? Which is why it's so multifactorial, and why obesity is such a multifactorial cardiovascular risk. I'm going to pretend like this is the stomach and not really the liver, because there wasn't a really good way for me to put it there. GERD is a huge thing. And what about in your bones right here, when it's just sitting on your bones? Just do it. It's degenerative disease, right? Stress in your joints. So it's a really big problem. And that's kind of why we care about it. And that's all. So we need to treat it. And the question is, how do we treat it, right? And there's like a three-prong approach. One is lifestyle, which I feel like is the least inherently interesting, but of course is the bread and butter. But we'll go through that in a way that I hope is very practical. Pharmacotherapy, which is underutilized in residency practice, and we can talk about that. And bariatric procedures, also underutilized, but in a different way. Okay, so I'm going to talk about lifestyle, and just one word to just, if you guys want to read the slide of some quotes from people in this 2,500 women who were recruited for a weight loss study. You know, when people are overweight, they experience a ton of bias in their life and a ton of stigma and much internalized stigma. And doctors are not helpful. I mean, all these studies basically show that doctors, at least 2/3 of them, or at least 2/3 of patients who are obese experience stigmatization from their doctor. And from our perspective, like transference there, we're obviously going to give compromised care, but also people are less likely to come to us if they don't trust us and feel like we're stigmatizing them. And there's lots of other diseases where you could say that people are at fault, and we're not going to even talk about whether or not it is people's fault, but we don't look at them and punish them. Like people come in with lung cancer, we're not, I would hope, not coming in with the same kind of stigma that I think a lot of people with obesity come in. And it's hard. So just to come in and say, oh, you're overweight, you have to lose weight, is not necessarily the most effective, definitely not the most sensitive. And it's something we should be cognizant of before they even walk in the door. And these are just some terms to avoid and terms to use. And there's things we can do in the waiting room. And there's a lot of information out there about like kind of how we can make it less stigmatized for people to come in and feel welcome. But we're not going to go into that any more than this today. So we're talking about lifestyle. There's the 5 A's of obesity management. I'm not going to go into this in depth, but it's just like the 5 A's of alcohol cessation or smoking cessation. And it's basically just, we ask first and then we assess. So Nora, poor thing, because you're right there. Do you feel comfortable just reading off bubbles as I let them appear? Are you in a place where you could do that? I don't hear from her. Okay. Can you?
Can you repeat? I'm sorry.
Are you in a place where you can speak?
Not really.
Okay, not really. So we're not going to do this. We're not going to do it. Okay, Dr. Horowitz, you were there and weren't there. Do you want to read?
Yeah, I can read.
Okay, I'm just going to pop up bubbles just because I don't want to be talking the whole time. And these are just examples of what to say when a patient comes in the room, okay?
Would it be all right if we talked about your weight today? I'm concerned about your weight because I think it's causing health problems for you. Do you think your weight is causing problems for you?
Really good acting. Really appreciate it.
What do you think about your weight? Based on your height and weight, your body mass index or BMI is 40, which falls into the obese category. Obesity has health risks. In fact, your weight can be contributing to your diabetes. The good news is that even small amounts of weight loss can improve your blood sugar.
Thank you. Thank you. These are just examples of, of opening statements that are not judgmental, that just open up the conversation. Okay. I'm gonna move this over. Sorry. And you just want to open discussion. The chances are people have thoughts about their weight. So if you just start by saying, what do you think about your weight? I guarantee you that everyone has thought about it before. Perhaps something that they think about every day of their lives since they were kids. And they probably have thoughts about what it's doing to their life or how much they care or what they've tried to do. And just asking the question, you can get a lot of information rather than just saying, you need to lose weight or bad things are going to happen, or this is the reason why you are experiencing these 20 different problems. Okay. It's important to keep that in mind, and just like everything else in medicine. So then we assess where they are. I'm sure you guys all remember these stages of change model, from pre-contemplative to ready, really action maintenance. There's lots of ways we can do this. Some people can do it as a gestalt. You can give people a checklist in advance. Motivational interviewing is the cornerstone. I'm not going to go into all of these. I mean, people can take pictures. I can send it. These are all really effective. One of the big things I want to point out is avoiding arguments. Arguing with patients, especially when they have to do with any addictive behavior, is not appropriate. There's a term called rolling with resistance, and just kind of shifting and deflecting or reframing. And I'm happy to go into it. I'm happy to answer any questions about this later, but it's important to be very intentional with your language. And when you're talking to somebody about motivating themselves to behavioral change, because as everybody here knows, like changing the way you live your life is a very, very hard thing to do, even with great motivation. So it takes discussion and it takes some sensitivity. So we advise them, okay? And what's the goal? I'm sorry, I didn't even realize anything's in the chat. So you guys answered. I'm trying to think, can I see the poll? Is that possible or no?
Yeah, 1 second. Let me just share the results.
Okay.
So do you see it? I can scroll
Yeah.
down.
Okay. So nobody got it right, which is very interesting. So losing 5 to 10% of your body weight does many, many things. Absolutely. But it does help fertility, and that has to do with endocrinopathy. That happens from the pro-inflammatory state. It does help OSA symptoms, does help glycemic control. It absolutely helps cancer risk. It does not decrease LDL, but it increases your HDL, reduces triglycerides, improves kind of the pro-inflammatory state. So it's still really, really great, but it doesn't actually do the LDL. And hold on, it's not letting me click. This is just a list of other conditions. If you think of it all as pro-inflammatory and not pro-inflammatory, this is why most of these things, the etiology of most of these things being helped. And you want to kind of figure out a long-term strategy and treatment options, okay? So then you want to agree, which is the next step. So you agree on making a change. Great. Lifestyle, there are 3 parts of it. There's what you do, what you eat, and how much you move. And those are the 3 pillars. So I'm going to try to make it really really concrete. Okay. So it's important that the goal is, it's called SMART goals, but basically it's specific, it's measurable, it's achievable, it's realistic. Okay. For a lot of our patients, what do you tell them for behavior? I'm going to go through these, and if you guys can guess what some of these pictures are, great. I'm going to assume nobody's going to guess this one because I couldn't think of a good thing to do. Basically, one thing you can tell people is just put a fork down in between each bite of your meal. It's kind of like weird and stilted, but that's a behavior you could do. It just promotes satiety. Same thing, just every time you feel hungry, first start with some water. Instead of using really big plates, use really, really, really small plates or in medium plates, and that will just help with portion control without thinking about it. Avoid distracted eating. We all do it, but just like with the people with insomnia and everything, like if it's not a problem for you, great. But if it's a problem for you, distracted eating just, causes kind of habitual response. You want to do meal planning in advance if possible. People can cook in bulk, freeze portions ahead of time. And anything healthy should be at eye level. And these are just really, if you can just remember one of them, just say to a patient, these are all behavioral things that everybody can do. It does not matter how much money they have, right? So these are some things that are behavioral and are evidence-based. Okay, and now I don't remember what they said about what's free. Oh, thank you. Let's see.
Which question do you
Okay,
want?
so notice only 5% of people, I don't know how many people did this daily weight. So that's what this is. So this is another cheap behavior, self-monitoring. It has been shown again and again to be effective. So look at this study about what weight loss is with daily weighing versus nothing at all. And there's nothing else, there's no other intervention than daily weights. It's extremely effective. It helps. We don't know if it's because of people's awareness and habits of triggers, but it is really effective. So it's something that for certain patients is a good idea. All these studies have shown there's no adverse psychological outcomes, including binge eating, mood, body dissatisfaction. That being said, I still would hesitate to bring it up to people that I think are prone to a lot of self-blame or to kind of extreme behaviors, because I don't know if that's really productive. But the evidence says that it shouldn't make a difference. I don't know. You can definitely tell people to write down what they eat every day. Any apps are great, like Fitbit, Noom, Weight Watchers, MyFitnessPal. All those are great. A lot of our patients can't do that, but most of them, if we can get them a scale, can do this. And so this is just like an quick and easy thing you could just say one time and be like, okay, why don't you just weigh yourself every day and then come back next time in 6 weeks and we'll talk about it further. It's easy, okay? Now, the question is, what is the best? what's the best diet? So, you know, DASH diet, Mediterranean diet they're great for cardiovascular protection. They're great for lots of reasons. If you do very low calorie diet, you can lose weight fast, but you'll rebound. But again and again, studies show, honestly, most diets have a lot of caloric restriction as kind of the basic element. And as long as somebody can stick to it, that is the one that's most important. So it's really about the patient preferences and what they can do in their life. You know, I'll speak for 1 minute about time restricted feeding or intermittent fasting. It's all the rage. There's very mixed evidence in terms of its either safety or efficacy. You have to make a lot of the issues are that people will then, in the time they eat, will actually eat more calories than they would have besides that. So you have to just make sure that, once again, if somebody wants to try it, you monitor closely, see if it's actually effective, and be very clear about maintaining a healthy lifestyle in between it. So it's something that if somebody really wants to try, go ahead. Even though the evidence is iffy, we'll see. We'll see how it kind of plays out over the next few years, but just make sure you monitor. Okay.
Is it okay to ask questions in the middle? I'm sorry.
Oh my gosh, please.
Hi, I'm Ariella.
Hi, Ariella.
I just wanted to ask, do you like how long do you usually give it as a trial? For example, if you're doing one of these interventions, is 6 weeks usually how much you would say, okay, this person is not working for them, or shorter than that?
No, it should be 6 months. I do 6 weeks in terms of compliance and adherence, because that's still a long time for somebody to be able to keep a diet.
Excuse me.
Yeah, I mean, because really, listen, all trials are a 6-month weight loss, at least. Like, really, people don't measure before. There is supposed to be a weekly weight loss, but really, because of like variations, we wait for that. But definitely adherence. Have you been able to do it? What have you been eating if you've been doing time restricted feeding? That can be done at 6 weeks, but I wouldn't look for outcomes earlier than 6 months, to be honest. Obviously, if it's going in the wrong direction or there's extremes in one way or the other, then that's helpful. But I wouldn't give up on something if somebody's able to adhere to it before 6 months, personally.
Okay, I'm just thinking about in terms of the counseling that somebody would say, well, if I'm weighing myself every day and it's not changing, like the psychological.
Yeah, but if you think about how much any of this is going to help per week, you know, we're talking about maybe like ½ kilo if we're really lucky a week. Like, it's not going to be, none of this is going to be extreme, and the whole point is that it's supposed to be chronic maintenance. But yeah, I mean, I think it's worth trying, and it's worth seeing how they do. And if somebody hates it, it's not going to be sustainable anyway, right? If they're like, I cannot weigh myself any day anymore, doctor. Doesn't matter if it's effective, because if they stop it, what does that really do? You know, I mean, it could still be helpful short term to just force people to be aware and like just check back in, but I wouldn't go crazy about it.
Okay, thank you.
Thank you. Please. Yeah, no, please. And this is why, one of the reasons why I hate Zoom, and I'm sure you guys are all completely sick of Zoom, because it's like, it's stilted and it's like kind of weird to interrupt, but it's like, really, please do. Okay. So for our patients, if we tell them, please eat healthy and organic vegetables, I think we all know that's really impractical. It's honestly impractical for maybe residents or lots of people, like, to just, because really, really healthy organic food can be very expensive. So what can we do? And I'm just going to give very quickly some very easy things we could do that will help people that are like, I just don't have access to healthy food. So meal replacements are actually a really good option as long as you don't do it more than 1 to 2 meals a day. It's shown to increase success for diets. You know, it's convenient. There's fixed calories. It's good for stimulus control. It's inexpensive. This is just an example of one from the American Board of Obesity Medicine that they endorse. It's $6 at, you know, Chiefs, can you please text Dr. Andrilli and tell him not to call me in the middle of academic half day? I'm joking, but tell him, seriously, can you text him and tell him that I'm doing a lecture?
Yeah.
Okay, so okay, so then of course you can eliminate or decrease liquid calories. Let me put something into the chat right here. Oh no, will this work? Okay, he called me twice. I guess I'm gonna have to pause for a second. I'm giving an academic half day. It's okay. Oh, it's in the Teams share drive. I just sent an email about it. I'll resend it to you. Yeah. Okay. You have to get onto Teams, but I'm literally on Zoom with the second and third years. Okay, bye. Only for him.
Actually, a 97, I think, is perception.
I know he is. I know. That's why he's up.
Okay.
I apologize, guys, but I have to pick up for Dr. Angeli. Okay. So anyway, liquid, get rid of liquid calories. That's an easy one. My plate can be helpful for some people if they have no sense in the beginning. I don't love using it, but you can. Frozen vegetables are a really good and cheap thing. If you look, this is like $1, right? If you use canned produce, just tell people to wash off the water before, because there's a huge amount of sodium. And then in-season produce is always cheaper. And of course, we're lucky that we have NYC green cards, and in the neighborhoods that are, if they're in the local neighborhoods, they're actually pretty, as long as you get the in-season stuff, it's actually very reasonable. And then one of my favorite things to do is just refer to nutrition. It's covered by insurance. We have it at the Ryan Center. It's a way that people can sit down, really talk about what they're eating, because we don't have time for that, right? So we can say one thing during the visit, like one behavioral thing, like, use smaller plates and make sure you're not having soda. But it's very hard to go through their day, figure out exactly what diet works for them. And we can utilize the dietitian. Later, I'll put into the chat, there's a book that are called Good and Eats, under $5, and it's delicious. And it's just not letting me kind of click into there, but I'm going to click into it later and put in the chat, and I recommend that everybody looks at it. Okay, so that's that. And then we'll talk about physical activity. So this is what the ACT recommends for weekly physical activity or daily physical activity per at least 3 to 5 days a week. The problem is that even if you do this, you're probably not going to lose weight if this is all that you do. And this is very disappointing because we love physical activity, but as monotherapy, it's really not so effective. So exercise alone results in a mean weight loss of 0.1 kilograms per week. And then total, you plateau 2 to 3 kilograms, even if you do that every week. So this is not a significant amount of weight loss. Usually it's maybe 2% of your initial weight, even with like really great exercise. So that's just something to keep in mind when you're talking to patients and you're saying, okay, I need to, like, if all they want to do is have weight loss, really, it should be combined with diet intervention, or diet intervention first, then physical activity. Of course, physical activity is amazing for your cardiovascular health. It's amazing to get rid of like the effect of the diseases of obesity. It improves musculoskeletal, cardiovascular, sexual health, cognitive health. So like, I'm not saying anything bad about physical activity. It's great. It's just not effective as monotherapy for weight loss. Okay. However, once you lose weight, it's extremely effective in preventing weight regain. So once somebody has lost weight and it's diet alone, we really should encourage them to then start an active lifestyle, because that is the biggest predictor of having somebody not gain the weight back. Okay. Okay. And the last thing is, okay, so what do we do? How do we tell people? Okay, let me go back. What do you think are some of the challenges for our patients with limited means to be able to work out? Anyone?
Sometimes they just cannot go outside because where they live is not safe, or at least they don't
Yes.
feel safe.
Exactly. And so it limits the outdoor activity. Obviously, gym memberships are expensive, and so is home fitness equipment. And honestly, a lot of people work multiple jobs and you just don't have as much time. And so those are all things that we really have to think about when we say like move more. So here's some things you can do. I like this one in theory. The reality one is not so easy. If somebody has both a manual wheelchair and an automatic, ask them to spend a little bit of time per day in the manual wheelchair. It's hard, but that's something you can do if somebody's in a wheelchair. Jumping rope, sure. But really walking around 10 minutes in place, maybe like when you have a commercial on, or during a certain commercial, during a certain part of a TV show, you could try. Right before you have a meal, 10 minutes before you have your first bite, just walk around for 10 minutes. You could try to do that. This is one thing we use all the time, which is get off of your stop 1 to 2, when you're on your way to work, 1 to 2 stops in advance. There's always wall presses, which are kind of cheap and easy. And my favorite, once again, this is like a nitty gritty, refer people to physical therapy. This is like they get their own mini gym session with somebody that knows what they're doing. We'll teach them home exercises. It will be tailored. most of our patients have a reason to refer to physical therapy, like improved gait or back pain or foot pain, like for all the reasons we discussed, many people with obesity have joint pain. That is an indication to refer to physical therapy. We can't, if they don't have time for it, they don't have time for it, and we can't do much about it. But if they do, it's covered, right? And that's something that I usually utilize and has a lot of different benefits. Okay. So then the next part, we're going to go to pharmacotherapy, and this one I'm going to ask you for your input a little bit more. Just checking the time. Okay, so the rule of thumb basically is most pharmacotherapy is effective at like 5 to 10% weight loss, and you should see it at 3 months. So Ariella, that's the answer for this one. So really, you should see a 5% weight loss in 3 months, or kind of give up, or either augment or change it. And if you see, the indications are pretty loose. Like if you're over 27, if your BMI is over 27 with a comorbidity, or over 30, it's indicated and part of the algorithm. It's not true the algorithm because it's really confusing, but it's part of it. I'm going to take 1 second to talk about the pathophysiology of this a little bit. And that's like, we all talk about lifestyle. I've heard a lot of residents say, they haven't even tried yet. So like, why would we consider something else? And lifestyle is very important for all the reasons we discussed, but it's very hard to lose weight. I'm sure anybody that's tried to lose weight can sympathize with, even if they only have to lose 5 pounds, how difficult it is. And if you look, this is an old study, but it still makes the point. If you track people that did both very low calorie diet, behavioral modification, and combined, still when you're at 5 years out, like, it's really hard to maintain it. So the question is why? And the answer is that appetite and weight regulation is super complex. It's not the same as energy in equals energy out, or energy in has to be less than energy out. Just is not the way that it works. It's the way that we like to think about it because it's so simple. It is not the way it works. It's an imbalance of physiological neurohormonal forces that basically weakly resist weight gain and strongly resist weight loss. And that's just because evolutionary, that's why. There are lots to focus on. I'm just going to talk about these 2 hormones. If you guys remember, anybody that was in my talk last year, I talked about this will be quick. So there's 2 important hormones tested on, you will be tested on them: leptin and ghrelin. Leptin is a satiety hormone, ghrelin is the hunger hormone. Okay, so leptin is made in your fat cells, in your adipocytes. So what happens when people are obese? What happens to their leptin? Anyone? Can't see the chat. Yeah, it's high. Thank you, Frida. It's high, right? And so when people who are obese tell you they're not so hungry, believe them, right? That's very pathophysiologically likely. But one of the things that we think happens is, just like there's insulin resistance for diabetes, we believe that there's probably leptin resistance that's related to that. So people can have very high levels of leptin, just like diabetics can have very high levels of insulin, but it's not going to the receptor. So people aren't feeling the satiety. And even more so, once people lose weight, what happens to their leptin? It goes down, right? Because their fat cells are going down. So they lose their leptin. So then the ghrelin becomes, disproportionately higher, and people get hungrier. Other things go down, like GLP-1, PYY. I'm not going to go into it, but it's hard, right? It's hard to lose weight and to overcome those forces. And our CNS pathways are really important, So the thing that I was just talking about is the homeostatic mechanism, because GLP-1, PYY, leptin, insulin, honestly, all works on the hypothalamus to affect hunger and delayed gastric emptying, lots of things like that. Then there's a hedonic pathway, which is basically like a reward pathway. And there's a lot of information that says, like, processed palatable foods stimulate the brain's reward center. It actually stimulates opioid release and decreases your stress response. So in that way, you get this addiction-like behavior, like reward system that happens. And this is important when I talk about pharmacotherapy, which is why I had to go into this. Okay. All right. Chiefs, I'm going to need somebody to read, and I just prefer that you call on them. It doesn't matter if they're on their video or not on their video. I don't care.
Yeah, Randy.
Sure.
Thank you.
30
And it's
years
just
old-
reading. You're not going to be the one that has to answer anything.
That's okay. 30-year-old female, BMI of 39, history of hyperlipidemia, diabetes, hypertension, well controlled, depression, smoking, presents for a follow-up visit. She has tried to work out 3 to 4 times per week and has been reasonably compliant with a low-calorie diet. However, she has reached a weight plateau and is coming to you for advice.
So this is this person. So current meds, metformin 500, glyburide 5, Lipitor 40. All right, guys, I'm going to force you to be interactive. Somebody tell me what I do now. Oh, do you guys see all of them? Maybe you don't see all of them. Here we go. Now you can see them.
So I would say take a little bit more history on the details of her diet to make sure that her low-calorie diet is actually a low-calorie and balanced diet. And also ask her for how long she has undergone those lifestyle changes. And then based on the prior slides, maybe introduce the idea of medications.
Yes, thank you. So absolutely. And so I want to focus on medications. You're right. I don't know who RCS is, but whoever RCS is, thank you. So you said try to switch glyburide for a GLP-1 if amenable to injectable. So there are two things about that. So glyburide, I'm just going to quickly show you guys here, and I'm going to, okay, so this are drug-induced causes of obesity that we should avoid. Not all of them. Tell me what here will not cause weight gain.
Alpetron,
What'd you say?
bupropion,
Yes. What else? Jardians, somebody wrote. What else?
That's Raul, by the way.
Yes, it's true. Everybody's saying EMPA.
Propanolol?
No, beta blockers do cause weight gain. Minimal, but they do.
Methotrexate.
No, methotrexate does.
gabapentin, I guess.
It does.
How about
Ah.
lithium?
Lithium does.
Oh.
Nortriptyline does not. Abilify, right? It's a second generation antipsychotic, so that does not. And Prozac does not. And Zyrtec, sorry, so second generation antihistamine. Everything else here does. And how many people do we know on these medications? Doesn't mean we can always take them away, right? Like if somebody's on lithium, I am not touching that, but it's good to know. It's good to know, okay? And these are all, some of these are modest weight gain, but they are in general weight positive. So it's just good to know. Obviously glipizide is like weight positive. And then the other thing that RCS said, and I don't know who RCS is, but thank you, is you spoke about GLP-1. Okay, and I'm going to send you to a video. I really hope this will work.
It's funny, every time you say triplets, I immediately think of 3 hot blonde 19-year-olds.
Sorry, I don't hear.
Drink your hair.
Somebody talking to me, or that's just,
I don't know who
Adoption
that is.
agencies. Oh, baby.
Okay.
Oh, this one is so cute. This one.
What is this?
that is. Okay, so I want to make sure. No, this is not the right one, sorry. But in general, I don't know, can you hear this?
Not right now.
Hear this? Okay, so let me try one more thing. I think, so you're saying that when I do screen share?
Yeah, there should be a pop-up that says share with sound.
Ah, I see it, okay. Share with sound. All right, I'm gonna have New England Journal of Medicine tell you guys about this and not me, so that I don't have to talk more. Okay, let me see how loud I can make this. Can you hear?
We heard the thing.
You did, okay, good.
Semaglutide is a glucagon-like peptide 1, or GLP-1 analog, that is approved for the treatment of type 2 diabetes. In some studies in persons with type 2 diabetes, semaglutide induced weight loss. In this phase 3 double-blind placebo-controlled trial, 1,961 adults without diabetes and with a body mass index of 30 or more, or a BMI of 27 or greater with one or more treated or untreated
you don't see
coexisting
video?
conditions, were randomly assigned in a 2-to-1
That's so
ratio
annoying.
to
Okay, let
once
me try
weekly
this.
subcutaneous
Oh, you know why? Because
semaglutide,
it's full screen.
titrated to a dose of 2.4 milligrams.
Now, So
or
I'm going to
placebo
restart it.
to diabetes.
Can you see
In
and
some
hear?
studies in persons with type 2 diabetes,
No.
semaglutide induced weight loss. In this phase
Okay,
3
guys, I'm gonna try
double-blind
this one more
placebo-controlled
time.
trial, 1,961 adults without diabetes and with a body mass index of 30 or more, or a BMI of 27 or greater
wanna
with one or more
send the
treated or
link in
untreated
the chat
coexisting
and I can
conditions,
just
were randomly
transfer it?
assigned in a 2-to-1 ratio
Yes,
to
I
once weekly
can,
subcutaneous
but I know it's going to
semaglutide,
happen.
titrated to a dose.
Okay. Really, last time, I promise.
Okay.
I promise. I'm going to stop. It's just really fun. It's, you know, like when there's something that share screen, share sound, this. Just gonna have to listen to it on this. Can you see that?
Not yet. Now, yes. I think it's
Peptide
gonna
1 or
work. Yeah.
GLP-1 analog that is approved for the treatment of type 2
No?
diabetes.
Okay, sorry guys.
In some studies,
But now they
Basically, the GLP-1, I'm very sad, and now Zoom is trying to stop me. I think Zoom is just really, really mad at me. I will send the link in the chat. You guys can look at it afterwards. I'm very sad. Right here. It's really sad. So you guys can look at it. It's a 2-minute study basically on GLP-1s and how effective they are at weight loss. Okay. So let me go back to here. All right. So that's extremely effective, and I recommend that everybody use them. It basically you can get like a 16% weight loss at 6 months. It's really, really impressive, even without diabetes. And both the scale trial is what I sent you a link to, and it's one of the preeminent trials. And maybe I'll try once more at the end, but I would just look at it. Okay. And then there's one more thing here that I can talk about, or 2 more things here. Pharmacotherapy that we can maybe do. Okay, so this person smokes. Can you think?
Dr. Edelman, we're not seeing your PowerPoint. We're seeing the NEGM
You can't?
website. I think you need to share the.
I did. I shared it.
PowerPoint.
I shared it.
Maybe stop sharing and try again and clicking.
Yep,
on
let me
it.
do that.
Yeah.
I think something's going on with my Zoom because it's shared. Now can you see?
1 second. It's black right now, but it's just maybe loading it.
So my Zoom keeps quitting.
Yeah, we can see it right now.
Open to one of us, we can share the screen.
Yeah, that's another option. If you want to email the presentation, I can share it.
Yeah, no, my Zoom keeps quitting. So I'm gonna try one more time. If not, what I'm gonna ask you to do is I'm gonna literally close my Zoom and reopen it. And during that time, show the video that's on the chat.
Okay.
If it doesn't work. So let me try this one more time because I keep getting these error messages from Zoom. So I don't know what's going on. Can you see this?
Yeah. Now we
Okay,
can.
good. So hopefully it's fixed. Okay.
And there's a question by Frida in the chat. How much weight loss can you get with that GLP-1?
So you can get up to 16%. It's really amazing. I really wish I could show you this. I'll show you the video, but it's unbelievable. And this is without any diabetes. Okay. So like the results in this group, people had like over 15% weight loss, and the mean weight loss was over 15 kilos. Versus 2 kilos in the placebo group. And this was after 6 months. Oh, no, sorry, this was after 1 year. So this is huge, right? Like 15 kilos versus is a huge weight loss. And so it's something that the problem is coverage. So if people don't have diabetes, it's expensive and it's really hard to get covered. So while I would love it, while it's approved FDA wise for anybody with obesity, we're not gonna be able to get it approved in the clinic. Okay, and so I'm just going to help you guys with these. So metformin can actually be used as adjunct to weight loss, and this person is not maxed out. And the thing is with metformin is that we think that it probably induces just like it increases insulin sensitivity. We think for those people, it probably also increases leptin sensitivity and GLP-1 sensitivity. So that's why we think it helps with people that already have insulin resistance and kind of the metabolic syndrome. it's equivocal in terms of being used as monotherapy without insulin resistance, but it's definitely something that is worth doing. And if you can see, it has some significant weight loss. So definitely for patients with diabetes whose BMI is over, or even pre-diabetes, from like what I do, if they're obese, I think it's worth trying. And once again, you check in 3 months. And if there's no difference, then you can even consider de-escalating if you don't think that they need it for glycemic control. And the last thing is smoking. So can people think of a smoking medication that also has weight loss?
Usually, like one of the choices for obese and smoker patient would be a combination of naltrexone and bupropion.
Thank you so much, Nora. Yes, it is. And so it's really effective. So if you see here, these are a bunch of the trials that are looking at Contrave. And that's the combination that you were talking about. And it's obviously, this is Contrave by itself. This is if you do with behavioral modification, the difference between that and then with diabetes. So it is very helpful. You know, and look at this, it's a small little scale, but you could see kind of the difference in weight loss between placebo and on the bottom are is weight loss with Contrave, so it's effective. Once again, we're going to be like about 5 to 10%. It works on the hunger center. So basically, what it's a norepinergic, norepinephrine, I can't even see, and any activating pathway, which is going to kind of increase your. So sorry, it's going to increase your kind of dopaminergic and a noradrenergic response, and it kind of works in your reward center. And what's great about the naltrexone is, remember how I was saying how like food starts an opioid pathway? So naltrexone, just like it works for like opioid antagonists, it actually works to kind of blunt the opioid reward pathway in the brain. And so the thing is, it's expensive, of course. So can we give Wellbutrin by itself? The answer is yes. So if you look at the study here, it's looking at the combination pills are at the bottom versus bupropion by itself versus on the top naltrexone and kind of placebo. So naltrexone monotherapy we don't think works, so I wouldn't try it. But if you can get up to 300 to 400 on Wellbutrin, then you can actually have some. We think it's about 3 to 5% weight loss. So it's not as good as the combination, but it's something, and it's covered by insurance if they smoke or if you need it for depression. Okay, so it's definitely something to consider that can be useful for patients because every little bit counts. Any questions? Okay. All right. Next one. Okay, I'm going to go through these. I'm very sad about the other thing. All right. She's just grabbed somebody. This is a quick one.
Any volunteer?
I can read. 29-year-old female, BMI 32, history of frequent migraines, IBS, pancreatitis, presents to ask for help with weight loss.
Okay, and this is, we're going to do pharmacotherapy. Can we do a GLP-1 for this patient? No, why?
Pancreatitis.
Exactly. They have migraines, so is there anything that we can do? Sorry, I'm just seeing things in the chat about Corinna, by the way. When you were asking FDA approved for weight loss, were you talking about the GLP-1s? Yeah, so, okay. Yes, so Topamax, thank you guys. So I'm just gonna go back. Thank you, Corinna. So yes, it's approved. I'm sorry that I haven't been seeing the chat. I have a lot of things on the screen. Yeah, so we don't use this as much as maybe we should, maybe we shouldn't, but Qsymia, which is phentermine and Topamax together, is very effective for weight loss. Besides the GLP-1s, it's the most effective. We don't use it partly because of stigma and partly because it actually has some medical contraindications. Just like the bupropion, it's a neuroepinephrine releasing agent. It is cheap, it is effective, but there's a lot of issues. So it's a Schedule 4 on the DEA, it's the pregnancy category X. Technically, for safety reasons, they're not supposed to use it more than 12 weeks. However, subsequent studies have actually shown no increased cardiovascular risk. So some people, especially in obesity clinics, will use it for longer. I have to tell you, I've never done it, but I still want to talk about it because we could. And part of the reason I haven't done it is because a big contraindication is if they have high blood pressure. So I don't know. I mean, once you have somebody with metabolic syndrome, it's very hard to see them without a high blood pressure. Anybody that could be getting pregnant, we don't want to do it. Anybody with kidney stones, because the Topamax, we don't want to do that. And glaucoma, it causes an increase in closed open angle and closed acute angle glaucoma. So you don't want to do that. Anybody with hyperthyroidism, right? And so if you think about this, like there's a lot of our patients that it's not appropriate for. And unfortunately, Topamax by itself is not really used by itself. So, you know, it probably doesn't, there's probably not a lot of harm to just using Topamax, but it's probably not so effective anyway. So, you know, unfortunately, that's kind of where we are for this, but it's something that you guys should know because it's cheap. Something that's not cheap is Orlistat. I'm going to go back to this patient for a second. Blah, blah, blah. Why should this patient not get Orlistat?
The IBS diarrhea.
Yeah, thank you. Right. So it's contraindicated with IBS for good reasons, right? Orlistat is expensive. It's extremely poorly tolerated. It's complicated. It has to be had with full fat meals. You can't, it's going to change the absorption of obviously Synthroid. You're going to have to be careful with warfarin. That being said, it does cause some modest weight loss. We don't use it long term. And the reason is because so if it's just a lipase inhibitor, right? So you don't put as much in your stomach, but what's that going to do? You're going to end up just eating more because it doesn't change your neurohormonal balance or the endocrine balance. So that's why long-term it's not great. Listen, it's low risk as long as you don't have any of these contraindications. So if somebody really wants it, you can try it. But it's often not the best long-term. Okay. And I just gave the answer away. I'm sorry.
There's a question in the chat.
Yes, what's the question?
Bujuir prescribed to patients who are overweight and not obese. Are these approved for that BMI category?
Yeah, it is for 27 plus with comorbidities like diabetes, hypertension. I would if they have diabetes, because GLP-1 and metformin, why not? I personally wouldn't for others, unless I feel a compelling need or the patient's really insistent, just because I prioritize, and usually there's a lot more to talk about. If the patient brings it up and wants to, it's technically approved for those indications, so they can. But definitely without any comorbidities, I wouldn't touch it until they're 30. All right, Dr. Prince, since you're maybe never going to take the boards, but maybe you will, can you read this mix-up question for everybody else that's going to take the boards?
No worries. 27-year-old man is evaluated during a routine follow-up visit for obesity. His last two visits, he had a BMI of 38. Despite enrollment in a 6-month comprehensive supervised weight loss program that included nutritional counseling, he's gained 2.3 kilograms, 5 pounds. He briefly tried Orlistat, but discontinued this medication because of GI side effects. His history is significant for type 2 diabetes and hypertension. He's on liraglutide, lisinopril, and metformin. Exam-wise, blood pressure 146/91. Other vital signs are normal. BMI of 39 now. Remainder of the exam is unremarkable, and an A1C of 8.2%.
And people could just put in the chat if they want to what they would answer if they didn't see the answer when I gave it away.
They're saying 8.
Yeah, thank you, everybody. And this would be correct if I can get it. Okay, it's correct. Okay, so we should consider bariatric surgery for people who don't lose weight with lifestyle interventions, who have a BMI of 40 plus or 35 plus with obesity related complications. Okay, and that's how we get to bariatric procedures, and this will be quick. I promise we'll be on time. And these are the indications, as I just said. I'm going to try to, so these are the different types of bariatric procedures. The two most common that you'll see are the sleeve gastrectomy or the Roux-en-Y. And the Roux-en-Y, I'm going to try to play. I don't think you'll be able to hear it because things have been not working with videos, but you'll tell me. Let's see.
Incisions are.
Can you hear?
I hear you.
Can? Okay. So let me actually skip this here. Skip. Here we go.
Now we don't hear, but we can see the video.
What'd you say?
We don't hear anything now, but we see.
Oh, you don't? Okay, it's not worth it. But you guys can look at what you can look. I won't, if it's not doing sound, it's really not worth it. Okay, so these are the very common ones. And we'll go into a little bit how to monitor it, but that's going to be extremely brief. But the point is, it really, really works. If you look at this weight loss. We've been talking about 5 to 10% with pharmacotherapy. With the switch, which I just didn't have time to go into what that is, it's 70 to 80% weight loss. This is huge, okay? And it works for basically every endpoint that we care about. So for diabetes, up to 75% of cases resolve. Hypertension, 2/3 resolve. OSA, 80% resolve. And of course, improvements in hyperlipidemia. And there's significant improvement in mortality. And none of this it's not surprising the survival rates are astronomically high, and the risk versus benefits of doing this is really very dramatic for patients. So this is something that we should really, and now they're so safe, we should really be encouraging our patients to consider. We don't do this banding anymore, and that's because it's kind of just making it's reversible, has complications, and just makes the stomach small. It doesn't get to the root of what is I promise I will be done by 2, of why bariatric surgery works. And the question is, why does it work? So there are lots of reasons. If it was just restriction, just like everything else, it wouldn't really work, because the people are just going to eat more meals, right? Because it doesn't get on the hunger mechanism. And we don't think it's malabsorption that makes it work, because we have micronutrient deficiencies, but not macronutrient deficiencies. And so we think it's neurohormonal. And I just want you guys to look at this. This is the last kind of really chart to look at. When you diet, just like I kind of was talking about before, your leptin goes down, your PYY goes down, your ghrelin goes up, you get hungry, and you end up gaining weight again. And see, it's an average 80% weight regain in 5 years. Bariatric surgery, for reasons that I'm happy to discuss, but I don't want to go over time, actually decreases your leptin levels. It increases your GLP-1 level. It increases your PYY level. And that has to do with the diversion that happens. And you basically have a new set point. And that's why we think it's so effective, and so effective long-term, especially for metabolic syndrome. This is just another way in which in all the hormones that it affects. This I can just send to you, which is how we monitor it postoperatively, because we do have to monitor micronutrients, but either you can take a screenshot, I can send it to you. That's really it. And that's it. Okay, guys, this is the summary, and I hope that you learned something. I know that it's a hard disease, and it can be kind of a boring disease, but it is really, really important. And I'm sorry that we're on Zoom. We all have Zoom fatigue. These are 2 of my daughters. We're all over it. And so I really appreciate your time and attention. I know it's not easy. And that's it. So let me know if you have any questions.
There's a question from Madeline in the chat. She was asking about bariatric surgery. How about after 2 years, long-term 5 to 10, anecdotally, they regain the weight?
No, they don't. They regain a small percentage. You can do 5 to 10%, but that's one of the reasons. And it depends what kind of bariatric surgery they have. But for Roux-en-Y, you get a 5 to 10% weight regain maybe in 6 months, but you shouldn't have that much. I want to see what's hot off the press. Just tell me, on God.
Endoscopically placed intragastric balloon for.
Yes, so I can talk about that for a second. Yes, so the balloon is really, really cool. And I know I stopped saying the balloon is really cool because it's basically you swallow a balloon, it expands in your stomach. It's only FDA approved for 6 months for short term, and it's really good for people to start weight loss because it's same thing as the banding, right? You're just giving less surface area to the stomach, so it induces early satiety. It's not so great for long term for all the reasons. For all the reasons that we discussed before. It's probably not great long term, but it's really good for short term. And also, some people we need a bridge to be able to even get them other kinds of surgeries or bariatric surgeries. So it's a really exciting thing. And some, like Columbia is already using it. So there's that. And I'm going to try to get the pharmacotherapy. Lady asked me, yes, you can give it for prediabetes. It's still not going to be approved. So it's annoying because GLP-1s are so effective, and I don't know why they give us such a hard time for something that's so effective. But they do. And I'm going to put this Good and Cheap thing in the chat for everybody to see. It's an amazing book. It's like a 10-page PDF on things that are cheap. Is there data pointing on one way for time restricted feeding and cancerous? No, not that I've seen yet, Kirtana. But we could talk about it offline for a very long time. Time restricted feeding is it's just last year or 2 years ago was really hot. So they started to do a lot of studies on it. And there's a lot of great theories on like why it should work. But the point is not yet. How much does which one cost without insurance, Madeline? GLP-1, it's expensive, so it's about $400 a month. So most people, it depends on who it is, but a lot of our patients won't do that. Lady, 6 months, people have to wait 6 months after surgery before considering after bariatric surgery before considering pregnancy. That's the answer to that. Anybody else?
Kirtana, is there data pointing one way for time restricted feeding and cancer risk?
Yeah, that's what I was talking to her about.
Oh, sorry.
I'll talk to her about that offline. It's long, but unclear. And anybody else? I really recommend just clicking my PDF. I'm sorry that the New England Journal one didn't work. It's really fun. They have like these 2-minute videos that just explain the whole journal article. So that's all. All right, guys. Thank you all so much. I hope you learned something. Really excited to stop talking. And next time in person.
Thank you, Dr. Edelman.